Morning. The topic today will be subarachnoid hemorrhage, and in the next 20 minutes we will explore the pathology, the complication, and how can we deal with the complication in the intensive care setting. Thinking about stroke, SIH accounts for 5–7% of the overall stroke, so the numbers are not so high. But if you think about the incidence of cerebral aneurysm in the population, you have to think that many people harbor an aneurysm, 2–3% of the overall population. So it's a frequent condition. And if you think of the vessel where they run inside the subarachnoid space, the space where CSF is, vessels are included, and there are trabecula in this area, the vessel run in this space, and under some condition and having some predisposition, the patient could have the development of an aneurysm at the bifurcation of the vessel. And the aneurysm with time, with pressure, with flow, increase in volume, and sometimes it breaks. And there is a bleeding in this space. And the bleeding is, the incidence of the bleeding is 9 people every 1,000 people a year. So thinking about Paris, we are thinking about 300 cases a year in the city of Paris, excluding tourists. And the problem that comes is that we have a bleeding. The bleeding is an important condition because the patient experiences the most important headache in his life. And the problem became immediately ischemic. It's an hemorrhagic condition with a lot of ischemic complication. And the first one is that the flow reduced at the moment the aneurysm rupture. If you look at the intracranial pressure in a patient recorded was in the 80, one of the first recording, ICP goes up, and the perfusion pressure inside the skull is very low, and the patient loses, more severe case, there is a loss of consciousness at that stage. But after the bleeding stopped almost immediately, because there is a vasoconstriction and platelets extravasation close and reduce the bleeding immediately. But if you look at the CT scan at the end, this is a cartoon, we can have a bleeding in the subarachnoid space. Sometimes we have some hematoma. We can have a subdural hematoma for some location of a cerebral aneurysm. And we have sometimes bleeding inside the ventricles. If you think of the early phase, what we described till now, we have some mechanical effects that come from the rupture of the aneurysm, destruction of the brain tissue, mass effect, and hydrocephalus if blood goes inside the ventricles. And we have immediately an ischemic condition where cerebral blood flow goes down due to high ICP, and CPP goes down, as we saw before, and we have some microvascular constriction. So it's a bleeding with very linked to ischemic condition. And if I'm able to go ahead, okay. This mechanical and global ischemic effect produce a couple of conditions: early brain injury, cortical splitting depression, and cellular changes. If we think about early brain injury, we have a lot of changes happening after the bleeding. Activation of inflammation, for example, because the blood goes in the subarachnoid space where it's not usually present. We have molecular alteration, nitric oxide dysfunction, oxidative stress. We have hypoxia due to the low flow. And we have, in more extreme cases, cell death or small area of cell death, and brain edema due to the opening of the blood-brain barrier due to the presence of blood, and we will see in a while. This is called early brain injury. It's a phenomenon happening immediately after the bleeding. And if we look at the blood-brain barrier, in the upper part of the cartoon is the normal one. In the lower part of the cartoon, you can see a less pertinent, more open blood-brain barrier due to metalloprotease, due to platelet activation, and the blood barrier is not competent as in a normal subject. The other phenomenon happening almost immediately or in the day and hours after the bleeding is the fact that the neuron and the astrocyte swollen, and there is some difficulty in keeping the normal difference in the potential across the cell. Normally is minus 70 millivolts. Is the neuron swollen and there are difficulties in managing the flow of electrolytes, the internal potential is quite different compared to the normal. And the problem is that when we have some stimulation, some excitation of the neurons, and we can see that according to the normal condition in the swollen neuron condition, the so-called cortical spreading depression, the stimulus producing normal condition and increasing regional blood flow, in this condition produce a fall in the flow, and the flow becomes not sufficient for keeping the needs of the cell. And if you look at the microvascular, due to the cortical spreading depression, you will see a reduction in flow. So there are other potential ischemic conditions, and there are a lot of cellular change. The most striking are the reduction of nitric oxide, the increase in endothelin-1, and we will see later on a lot of inflammation starting from the bleeding. But after this cerebral blood flow arrest, the subject tried to react. And the physiological reaction is an increase of the blood pressure for keeping the perfusion, is an increase in catecholamines for keeping the perfusion. And we will see later on how this Cushing response, the arterial hypertension, the increase of catecholamines produce a lot of extracranial damage, cardiac and pulmonary damages. And in the early phase, after this increase in pressure, usually the bleeding stops, and we have more severe cases in which there is no reperfusion of the area, and there is an ischemia or death of the patient in more severe cases, or reperfusion later on with normalization of the pressure. We are intensive care doctor, and we have to deal with this patient coming in the intensive care, and we have to manage intracranial and extracranial complications. This is a small list of the possible complications, intracranial and extracranial. We will pass in review some of them and the treatment of them. We did collect some information on the management, and I'm suggesting you to download these two papers. They are free to be downloaded. There are two consensus on subarachnoid hemorrhage quite recent by the American Society Stroke Association, and with the Neurocritical Care Society we produced 21 papers on subarachnoid hemorrhage, reviewing all the evidence in 2011. Talking about the intracranial complication, I will focus on some of them because I don't have time to speak about rebleeding and others, and we will talk about high intracranial pressure, hydrocephalus, vasospasm, and seizure. If you remember what we say till now, at the moment of the bleeding, most severe cases have more severe bleeding, and usually these more severe bleeding are associated with higher intracranial pressure. If we take a look in this population coming from Philadelphia of increasing severity using ANTS or Glasgow Coma Score, doesn't matter, but increasing severity of the population is linked with higher intracranial pressure. And high intracranial pressure comes from two sources. The first one is what we described till now, immediate increase in pressure due to aneurysm rupture. And before the patient comes to the hospital, the problem is almost resolved, except in more severe cases. And we have an increase in intracranial pressure during the course of the stay of the patient inside the ICU. This is due to acute hydrocephalus, hematoma in some cases, ischemia. As you saw, there is a close link between ischemia and subarachnoid hemorrhage, and before having ischemia, the patient with some damage of the energy production will produce a cytotoxic cerebral edema, and sometimes in more severe cases later on we have also cerebral infarction. If you think about the pathogenesis of hydrocephalus, we have a normal volume, we have a bleeding, We have the obstruction of the normal cerebral blood flow because every heartbeat there is a blood flow, cerebral spinal flow inside the skull that is obstructed by the blood, and we have the obstruction of the reabsorption of the CSF. This condition produces an increase in intracranial pressure, and associated symptomatic hydrocephalus could be solved by a catheter in the ventricle. And this is the policy we are applying in our unit. If a patient is not obeying commands, or his World Federation on Neurological Surgery is hyperventricular, so is a severe patient, comatose patient, or the hydrocephalus is acute, the neurosurgeon put an external ventricular drainage immediately. But we want to define a therapy, drainage of CSF, and we want to know which is the pressure inside the system, so we close 15 minutes every hour the system for knowing the pressure inside. If the patient is severe and the pressure is high, we usually keep the extraventricular drainage open. In this condition, you cannot record the pressure, so we associate usually an intraparenchymal device, and we treat high intracranial pressure with a normal means. We said there is a close link between bleeding and ischemia, and this slide summarizes this concept because the blood in the subarachnoid space produces the so-called constriction of the vessel, the so-called vasospasm, that is present in most of the patients. They go to the angio suite. 60–70% of the patients demonstrate some narrowing of the vessel. Not all of them they will have symptomatic vasospasm, neurological sign linked to this reduction of the size, the caliber of the vessel. And blood, mainly blood, in the subarachnoid space produce this effect. And this effect, when will be very important, will reduce the flow and produce so-called delay ischemic neurological deficits. Blood is in a place where usually is not present, so oxyhemoglobin, hemoglobin is the main problem that starts to activate some cells and some effector of inflammation. A lot of attention in the last few years has been focused on nitric oxide, endothelin-1, and some trial also pharmacological against endothelin-1 started, but they failed, and we don't have any therapy for reducing this physiological response, this inflammatory response. And we have some possibility. We have to monitor this condition with transcranial Doppler and with clinical exam. And if you have some catheter or some tools for looking at the flow, you can take a look at the flow. And usually, when one of these systems will alarm you, we are used to go to the CT scan and we perform a CT perfusion. If we look at CT perfusion, when the neurological sign appears, this is a recent revision, a systematic review about that, the reduction of cerebral blood flow comparing the two hemispheres have an increase in mean transit time, 2 seconds here, and 15 ml per 100 grams is the mean difference you can expect. When the patient has severe vasospasm, you will have this kind of situation. And so, in the most severe patient with a positive CT scan, with a reduction of the flow, we go to the angio suite and we start endovascular treatment or infusion of drugs. But we need to monitor it, as we said, and we used to react. Reaction historically was to increase the pressure, the so-called triple H therapy, increase the pressure, hypertension, hypervolemia, and hemodilution. We learned in the last few years that the most important component of this is the increase of blood pressure, because if you look at the lower part of this slide, the oxygen tension in the brain in the strict condition at different times, only hypertension alone was able to increase the availability of oxygen. The other one, with hemodilution, reduced the availability of oxygen, local oxygen. And so the actual advice is to prefer hypertension to the other. And the guideline we wrote together with the American Society said that we have to try to test and induce hypertension, and we need to use usually peripheral vasoconstriction. We don't have time, we will skip this one. Okay, focusing in the last 5 minutes on extracranial complication, I think this slide will summarize many concepts. We have a response, the so-called Cushing response we define, and we have a stimulation of alpha and beta receptor. Alpha stimulation produces increasing pressure due to peripheral vasoconstriction or pulmonary vasoconstriction. The patient could experience, in more severe cases, neurogenic pulmonary edema. This is less common compared to the past, but is still present. And we have a beta stimulation with an increase in the contraction of the heart, and we have a so-called myocardial band necrosis that could lead to cardiovascular insufficiency. Looking at the past, we know that electrocardiographic signs are frequently present, and if in a patient that bled during the hospital stay, you can see there is a change, immediately change of ST level that returns back to the baseline after hours. And if we look at the reception of the heart for catecholamines, you will see that they are lost after this storm because the concentration of adrenaline and non-adrenaline is too high. And looking histologically at the heart, you can see there are bands of necrosis due to the maximal contraction, to the high concentration of catecholamines. This is linked to the severity of the population. More severe patients have more severe cardiac compromise, have more severe release of troponin, and this is linked to mortality. And if you do an echocardiography, they have an increase of regional wall motion abnormalities. And looking at the possible spectrum, in almost all the patients you can find some abnormalities, but a small percentage we have a severe left ventricular dysfunction. Many of others have intermediate presentation. And if you want to summarize this concept, going to the finish of my presentation, I will skip something due to time because we have only three minutes. And we have SIH, a stimulus. We have changing in electrocardiography. We have a ballooning of the apex because there is no good contraction of the heart, and this condition disappears usually in a week, and the patient recovers in a week. We are used to manage patients with cardiac failure, but in this case we have to balance two concepts, treating the heart that is failing, but treating also the cerebral perfusion of the patient, because we already say more than once that there are ischemic risks. And so we need to target euvolemia, and we start a standard management of heart failure. And in this case, I would like to stress the use of invasive monitoring. For example, in our unit, we are using the PICO device, but you can use whatever you want for monitoring the cardiac output of this patient. As you can see, the cardiac index is linked to the stress. More stressed patient, more high cardiac index. More stressed patients are more exposed to the risk or having a failing heart. And I think we need to monitor intravascular volume status, and we have only a couple of seconds for saying that we have a lot of pulmonary complication. Many of patients have a lot of impairment in oxygenation, more than 30% of them, and I think we can apply some concept we use in the clinical practice. Lung protective strategy, not documented in this setting, but useful in intensive care population, and I think could be applied also in our population, except for taking a look at the CO2, because we don't want to have very high CO2 due to the fact that high CO2 are linked to high intracranial pressure. We need to have a normal oxygenation, normocapnia, and we can safely apply PEEP in this condition if, for example, in more severe cases, we are measuring ICP. Going to the end of this talk, other general problems are present: fever, hyperglycemia. Most of these problems are linked to the initial storm. Fever comes from inflammation in this population, and we have a release of inflammation mediators in the CSF and in extracranially. There is a close link in neurological condition about outcome and fever, and I think we have to think in the last few seconds about the effect. Increasing fever in patients with normal autoregulation, we are able to compensate this increased in metabolic demand, and if the compliance is normal, we will have no effect. If the compliance is reduced, this increased cerebral volume produce an increase in ICP, and this is a negative effect. In the patient more severe, this increase in flow could not happen, and we can have some ischemic damage. I would like to stop here because I have 4 seconds. My last slide, I go there.